So the focus of my talk, as Dr. Goldhaber pointed out, is on patients with cancer. And if you sort of get no other messages from this talk, I want you to at least take home this slide. Why is it important to reduce the burden of VTE in patients with cancer? It's because 1 out of every 5 blood clots occurs in patients with cancer. So for those of you who are hospitalists or internists or hematologists or cardiologists that are focused broadly on the prevention, the public health prevention, in reducing the public health burden of VTE, it's vital that you not ignore the cancer population, because that's really a very, very high risk of population of patients, accounting for a large burden of clots in the United States. From an oncologist perspective, it's also vital that we reduce the risk of VTE because of this reason, which is that thromboembolism, both venous and arterial events combined, together are the second leading cause of death in patients with cancer. The number one leading cause is, of course, cancer. So once we do a lot of things to treat cancer, to prevent cancer recurrence, and we oftentimes forget to prevent or appropriately treat the complications of cancer and its treatments. And the number one cause here is thromboembolism. Nearly 1 out of 10 deaths in patients with cancer occurs because of a clot. The chance of dying early during chemotherapy, when I say early, it's in the first 120 days after starting chemotherapy, is 7-fold higher in cancer patients receiving chemotherapy who developed a clot versus those who did not. And the chance of dying from VTE in cancer patients on chemotherapy is 47 times higher than the risk in the general population. So these are really, really high numbers. These events are catastrophic for cancer patients, and it's vital that the oncology community in particular, and sort of broadly the health community, focus on this complication in cancer patients. A third important point to make about cancer-associated thrombosis is that it is rapidly increasing. These are data from over 1 million hospitalized cancer patients only between 1995 and 2003, admitted to over 100 United States hospitals. As you can see, rates increased steadily from 95 through 2003. Overall, there was a 28% increase in the risk per hospital admission of VTE. This is despite the fact that this is around the time that the Medinox data became available and other medically ill clinical trials results were available. So prophylaxis compliance rates actually went up during this time. Yet broadly, the trend has been to see an increased rate of VTE in this population. And oftentimes oncologists and other providers for cancer patients tend to view thrombosis as a complication of terminally ill patients, or as not being important in sort of patients in whom we are aiming for a cure. And so I like to point out the graph here, which shows that patients receiving chemotherapy that were admitted to the hospital had not only had higher rates of VTE, the rate of frequency of increase of VTE was also steeper in those patients. So 47% increase between 95 and 2003, which is the last year that we have good data available for at this point. Again, in-hospital mortality was also strongly associated with VTE. So the graph on the left shows sort of this rising trends in VTE in patients on chemotherapy for all patients, rates of DVT, doubling of rates of PE. And if you look at the graph on the right, we see rates of dying during the same hospital admission as a clot occurred if you did not have VTE versus if you had VTE. And every year that we looked at this, the rates were more than double. And some years it was even 3-fold increased rates of dying. And if you factored in all the other variables that are associated with mortality, we continue to see a strong and independent association of VTE during hospital admission and in-hospital mortality during that same hospital admission. And this again ties in very strongly with the risk of dying for cancer patients who develop blood clots. I'll only mention this once, but it's important to emphasize that especially for oncologists and others who are involved in cancer, we tend to view some of these complications of cancer as being separate from the cancer itself. So nausea and vomiting, for instance, febrile neutropenia are sort of classified or categorized in various oncology journals and societies as being supportive care. And the point I want to emphasize here is that cancer-associated thrombosis is distinct from those other cancer-related complications. We have good data now to show that tumor cells produce a variety of procoagulant factors, that this production of procoagulant factors is integrally linked with tumor biology, especially the regulation of angiogenesis. Many procoagulant factors are also proangiogenic. Many anticoagulant factors are also anti-angiogenic. And the upregulation of angiogenesis and the upregulation of the prothrombotic state in cancer leads to important tumor biology consequences that in general lead to progression of cancer, to metastases, and to increased mortality. So when we deal with reduction of VTE in the cancer population, we are not only reducing mortality directly from cancer-associated thrombosis, from a PE, from a stroke, but we are also reducing mortality indirectly by affecting this whole sort of cascade of events that leads to an aggressive tumor biology. So I wanted to cover sort of three different aspects of prevention of VTE in cancer. That's the title that Dr. Goldhaber asked me to focus on. And I have these separated out, but I have to tell you, and you made this point earlier today, I think these are artificial constructs. We tend to view these because of sort of the nature of medicine and the nature of how healthcare is delivered in the United States. But this is probably not going to be the paradigm 5 years or 10 years from now. I spent a very interesting half an hour with Zeke Emanuel, who's the president's senior advisor on healthcare reform, just a few days ago. And it's very clear that the leadership of both in the White House and in the Department of Health and Human Services is very focused on accountable care and this development of accountable care organizations. In the next few years, especially in cancer, it's very clear that there will be bundling of services and that this whole construct between hospitalized patients, the post-discharge period, and ambulatory patients will disappear. And it's up to us as sort of focusing on these different aspects of care that we not ignore one at the expense of the other. And so although I know this is a forum specifically devoted to hospital DVT prophylaxis strategies, I'm going to sort of talk about the continuum of care, not just in the hospital, but in the outpatient setting and in the post-surgical setting as well. So let's look at the data in the hospitalized medical population. There have been 3 very large randomized controlled trials in medical patients at high risk. You're very familiar with these studies: Medinox, which used enoxaparin; Prevent, which used dalteparin; and Artemis, which used fondaparinux. The unfortunate problem is that cancer patients comprised only a minority of these different study populations. The cancer patients comprise between 5 and 15% in each of these studies. And there have been no cancer-specific studies. And this is a real sticking point for oncologists as they try and make a prophylaxis happen in the inpatient setting. Having said that, however, each of these studies proved that prophylaxis in the hospitalized medical population, including cancer patients, is highly efficacious. A 63% relative risk reduction in Medinox, 44% in Prevent, and 47% in reducing VTE in the Artemis study. So clear results, consistent results across the board. And not only is it effective, but it's safe. Less than 2% rates of major bleeding in Medinox, less than 0.5% in Prevent, less than 0.2% in Artemis. So clear evidence from all 3 randomized studies that prophylaxis in hospitalized medical patients is both efficacious and safe. And so at this point, based on the NCCN guidelines, based on the ASCO guidelines, based on the CHEST guidelines, there's absolutely no sort of distinction about cancer patients. If you have cancer, unless there's contraindications, there's really no reason not to prophylax these patients. And I'll come back to sort of those guidelines and the evidence and sort of the reality in a few minutes. The second set of patients for whom prophylaxis has been considered to be both effective and safe is surgical patients. The data for major abdominal surgery, major pelvic surgery, major oncologic surgery is very well known to all of you. I will not repeat that. I want to make the point, though, again, speaking to the sort of post-discharge care, that the real risk now, especially in this era, is not in the surgical, immediate post-surgical setting, but it's in the extended post-surgical setting. These are data from Italy, but many other studies have repeated this as well. A large prospective cohort of patients receiving surgery that were followed for a period of time post-surgery. And as you can see, 40% of events occurred after hospital discharge. And again, it's not fair for patients. And again, when we are thinking of this in a patient-centered fashion, it's not fair for patients for us to say, well, we covered patients when they were in the hospital. It's not our problem that they developed the clot afterwards. It doesn't matter to the patient when that clot occurred. It's our responsibility as health systems and as groups of providers to decide how best to provide prophylaxis to patients with cancer and other patients, and to avoid events like this, which not only are harmful to patients from symptoms, but again, directly lead to mortality. So these are patients that for the most part underwent curative surgery for major abdominal cancers, for instance, yet you had 46% of deaths post-surgically occurring because of fatal PE, an eminently preventable complication that we've known about for decades now. So this is not a failure of medicine, it's a failure of inappropriate healthcare delivery, and we can't emphasize that enough. Extended prophylaxis has been shown to be effective in cancer surgery patients specifically. 2 very large studies have focused on this. Enoxacan 2, which randomized patients receiving a week versus 4 weeks of enoxaparin, and FAME, which was mostly cancer surgical patients, randomized patients receiving a week versus 4 weeks of dalteparin. The number here to remember are those numbers on the left of each of those graphs. 12% rates of VTE in patients who received a week of prophylaxis. So these are not patients who were not prophylaxed. These were patients who were prophylaxed for a week, which is currently the standard of care in the United States. 90% of surgical patients only get prophylaxis for a week. Yet, as you can see in these very well-run studies, between 12 and 16% of patients developed a blood clot. Almost certainly some of those blood clots led to a mortality, because that's just the nature of this illness. But with extended prophylaxis up to 4 weeks, we can clearly see a reduction, 60% relative risk reduction in Enoxacan 2, 55% relative risk reduction in the FAME study, demonstrating, I think, without any doubt that extended thromboprophylaxis is highly effective in cancer surgery patients, really no increase in major bleeding complications in these 2 populations. The third and largest group of patients is cancer outpatients. I use that term liberally. I think we've, in the oncology community, most of our patients are in fact outpatients, but patients transition far more frequently between the outpatient setting and inpatient setting, or limited inpatient stays for a variety of reasons. So I see patients who come into me 2 or 3 weeks after surgery for colon cancer. So they're really in the immediate or the extended postoperative period. They're still at risk for VTE. I send them back to the surgeon to get a port placed for chemotherapy. They're in the hospital for a day or so. They come back, they get started on chemotherapy. That chemotherapy often includes drugs, and we'll look at some of those drugs that are highly thrombogenic. They may include anti-angiogenic therapy, which is also highly prothrombotic. And then these patients may get complications from chemotherapy, like febrile neutropenia or an infection or pneumonia or a port infection, end up back in the hospital, in and out for a couple of days. So when we say cancer outpatients, they started off as outpatients, but there's a very rapid transition between inpatient and outpatient, and the inpatient stays are very limited in duration. And so we have to look not just at those 3 days that they're in the hospital, but at the broad picture of when cancer patients are most likely to get blood clots, and how can we identify those patients. Our other responsibility to cancer patients is also to not forget that even though the rates of VTE are very high, the current estimates are that about 1 out of every 5 cancer patient will develop a blood clot, which is very, very high compared to the general population. It's also important to remember that that means 4 out of 5 cancer patients will not get a blood clot. And so it's our responsibility to both focus on those patients who will get a blood clot, to appropriately prevent blood clots occurring in those patients, as well as to not prophylax patients that are at low risk or lower risk of VTE, so that we can avoid complications, even though complications of anticoagulants are rare. But it's still important to be able to avoid prophylaxing patients that perhaps may not need it. Until a few years ago, that was difficult to do, but as you've heard in many presentations earlier today, electronic medical records are changing the scope of what is possible. And they're changing the scope of individualized risk assessment. And what I want to specify over the next few slides is describe to you how complicated it is to assess for risk in a population that is already at high risk for VTE, but how we can bring together some of those factors and effectively identify cancer patients that are at very high risk for VTE. So broadly speaking, risk factors in the cancer population can be categorized as cancer-related, treatment-related, and patient-related. I show you these risk factors not to sort of burden you with the details, but to emphasize the complexity of how we can make these determinations. So the most important risk factor, of course, is the site and stage of cancer. There are certain cancers that we know very well are strongly associated with the risk of VTE. There's pancreatic cancer, for instance, glioblastomas, myeloma patients. The second most important probably is the initial period after diagnosis. So although cancer patients are at very high risk for VTE, the risk is not continuous over the natural history of their illness. It's highest in the first 3 to 6 months after diagnosis, then drops steeply in the 6 to 9 month period, although it doesn't reach the risk in the general population until 10 to 15 years after the diagnosis. And that's shown in this graph here. 53-fold higher risk in the first 3 months, dropping to 15-fold higher risk in the 3 to 12-month period, and even still a 3.6-fold higher risk in the 1 to 3 year period. So if we are to focus on prevention of VTE in the cancer population, it would make sense to start off with the group that's at highest risk, which would be in that first 3-month period after initial diagnosis. And then there are other factors such as histology. So for instance, in lung cancer, which we sort of seem to think of as a homogeneous disease, the risk is very different if you have a lung adenocarcinoma versus a lung squamous cell carcinoma. And I could sort of go on and on about this, but this is just, again, to emphasize that risk assessment is very complicated. In addition to factors that are sort of determined by the cancer itself, there are also things we do to cancer patients, treatment-related factors. Surgery we discussed already, hospitalization we discussed already. Cancer therapy is very, very complicated, and it is also very, very thrombogenic. This includes both chemotherapy, anti-angiogenic therapy, and hormonal therapy. And even within chemotherapy, there's a lot of nuance. Here we have a study of patients with a single type of cancer, G-junction and gastric cancer, with a single stage. These are all patients with just metastatic cancer alone. And they were given essentially the same chemotherapy, with the exception that one platinum drug was substituted for another platinum drug. And as you can see, just that one simple substitution led to a doubling of the rate of VTE in patients in whom everything else was completely controlled. So 15% rate of VTE in patients receiving cisplatin versus 7.5% in patients receiving oxaliplatin. And it's not just chemotherapy, it's supportive therapy too. So we often use, thankfully those rates have gone down, but especially in the mid-2000s, we were using a lot of erythropoietin stimulating agents to treat or prevent chemotherapy-induced anemia. And that turned out to be strongly related to the risk of thrombosis, and in fact was associated with increased mortality in a subgroup of patients. We've transitioned away from ESAs to blood transfusions, but blood transfusions are equally associated with the risk of blood clots, a fact that is not very well appreciated and has never, in fact, been studied in a randomized controlled trial. So many of the things we do to try and make our patients better can paradoxically lead to other complications, and we have to keep that in mind as well. And interventions such as central venous catheters also can be associated with the risk of VTE. A rapidly emerging field is biomarkers, and there's a whole host of biomarkers that can also help us predict the risk of VTE. So in addition to sort of the cancer-related factors and the treatment-related factors, there are variables that we can measure in patients. I used to initially just present sort of data on platelet counts and leukocyte counts and describe how they're associated with the risk of VTE, but it seems sexier to call them biomarkers. So these are biomarkers, but they're biomarkers that are part of the CBC. Every cancer patient in the world gets a CBC before they start on chemotherapy, and almost everyone gets a CBC almost every week. So this is data that's rapidly available to you, and through electronic medical records, these are data that you can obtain in real time when you're making decisions about prophylaxis. Other biomarkers, including tissue factor, D-dimer, P-selectin, and so on, are still considered investigational, although there's a lot of labs and a lot of research groups focusing furiously on developing these, and so hopefully we'll have some more data on this over the next couple of years. So it's very clear that from sort of these past few slides that although risk of VTE in the cancer population is high, the risk is also highly variable, and small changes can make big differences in risk of VTE. And to sort of better understand that risk, it's clear also that you can't just rely on one or two risk factors. You can't say, well, let's just treat all patients with lung cancer. You have to sort of look at some other factors in addition to them having lung cancer. And so what we did with this NIH-funded program was to focus on bringing together some of these risk factors, and we were able to do this with the help of a very large registry run by Gary Lyman, who is now at Duke. This registry accrued over a period of time about 4,500 patients, cancer patients, all starting a new chemotherapy regimen. And we were able to factor in not just the standard sort of risk factors such as the site of cancer and stage, but additional biomarkers, these are more simpler biomarkers, but they included the platelet count, the hemoglobin, and the leukocyte count, as well as obesity, which has come up already a couple times this morning. And we were able to assign points to some of these variables, and then we were able to test those variables both in a development cohort and then subsequently in a validation cohort. The risk score was very successful in identifying both patients at very high risk and patients at very low risk. Again, low risk is relative. This is not low risk compared to the general population, but within the cancer population, this is relatively low risk. This is only over a 2.5-month period, but the high-risk population had a 7% rate of symptomatic VTE. The low-risk population had only less than a 1% rate of, symptomatic VTE. The validation cohort, which was of about 1,500 patients, we had similar results, less than 1% in the low-risk cohort, close to 7% in the high-risk cohort, again, over a very short period of time, 2.5 months. And these data have recently been validated by the Vienna group, which followed patients for a longer period of time. We followed them for 2.5 months. This is for 643 days, almost 2 years. And rates of VTE were even higher, 17% in the high-risk cohort compared to 3% in the low-risk cohort. So between these two studies, I think it's very clear that you can identify cancer patients at high risk and that you can potentially prevent many of these blood clots and hopefully improve outcomes, including survival in these cancer patients with the appropriate use of targeted prophylaxis. A variety of clinical trials have looked at this sort of broad cancer population, so not focusing just on hospitalized patients, but looking at cancer patients primarily receiving chemotherapy with very variable results. And I wanted to focus on a couple of the more recent studies, again, to emphasize how different approaches have led to very different results. The largest study thus far, and this will only be the largest until June when SAVE-ONCO will be presented, but the largest study thus far is the PROTECHT study, which used a European low molecular weight heparin, napropirin, and randomized patients receiving placebo versus the low molecular weight heparin for a period of roughly 4 months in cancer patients initiating chemotherapy. 1,150 patients were picked, and I think although the study was successful, there's been a lot of skepticism about the results because of the low event rate. So patients were given daily self-injections of low molecular weight heparin for a 4-month period, but event rates in the placebo arm were just under 4%. And if you counted just the VTE events, they were less than 3%. So again, compared to the general population, very high. But when you're looking at hospitalized patients where they're getting treatment for a few days to maybe a few weeks, when you're treating for patients for up to 3 to 4 months, then you really want a much higher event rate and a much greater impact on VTE prevention. So the study was a major accomplishment because it was the largest study of outpatient prophylaxis. It met its primary endpoint for efficacy, and it showed that it was not only feasible, it was also safe to provide outpatient prophylaxis, but there was a high variability in rate. There were patients with breast cancer that had less than 0.5% rates of VTE and patients with pancreatic cancer that had 6 or 7% rates of VTE. And there was no survival benefit. So these results have sort of been taken as proof of principle, but have not been adapted in the oncology community as yet. That may change with the results of these two very recent studies. These focused on a very high-risk population, so only pancreatic cancer patients were enrolled. They were randomized to receiving sort of standard chemotherapy plus, in this study, enoxaparin versus observation. And here you can see that the rates were very high, close to 10% in the observation arm compared to 1.3% in the enoxaparin arm. The relative risk reduction was 87%, number needed to treat was 12, and major bleeds were actually higher in the observation arm than they were in the enoxaparin arm. The second large study, again focusing on pancreatic cancer, used dalteparin and again showed very high rates of VT, 31% down to 12%. And there's some reduction in lethal events and sudden death as well. Both of these have only been presented in abstract form, and we are all eagerly awaiting the manuscript results for peer review. Overall, all of these studies put together, this is a meta-analysis conducted by Nicole Cooter at Duke, who took together all of these different clinical trials done in cancer patients, several thousand patients by the time you add them all up, clearly showing that patients have improved outcomes with low molecular weight heparin prophylaxis, but that the improvement is restricted primarily to patients with very high risk, and that improvement in these studies thus far has been in the pancreatic cancer population. These, again, are the numbers of patients or the results from these different studies, plus myeloma patients who have been treated with both aspirin, warfarin, and low molecular weight heparin. Again, you can see the largest improvement is in the very high-risk population. So it's clear that cancer patients have very high rates of VTE. It's clear that there are different ways to identify those patients, the site of cancer, risk scoring, biomarkers. And it's clear that if you identify the right patients, you can clearly reduce the burden of VTE in that population. The important issue, however, is that there is still not a consensus, at least in the outpatient setting, which patients are most at risk, which patients will benefit from prophylaxis, how do you define high risk, and is it important to also show improvement in survival? But 3 ongoing studies hopefully will answer those questions. The first and largest will be presented in June at ASCO this year. This is SAVE-ONCO, which uses a new ultra-low molecular weight heparin. And I think it emphasizes how important the cancer population is because this drug is now only being developed for the cancer population. 3,200 patients were enrolled worldwide, and enrollment was completed middle of last year. The data set was locked in December, so presumably the results are available to the company, although they have not been shared with the public at this point. But the study relied on sort of the old school way of picking which cancer patients to prophylax. They picked patients with different sites of cancer like lung, bladder, GI, and ovary. They anticipate only a 4% rate of VTE, and it remains to be seen whether that's considered high enough for extended prophylaxis. A second study that we are running at UFR and Duke and expanding to a few other centers this year is a FAQs, which uses our risk score and only prophylaxis patients with a high risk score. And we have good initial results that allowed us to reduce our sample size. So we are planning on enrolling 400 patients. The event rate has been much higher than we had anticipated. So NIH just allowed us to drop our sample size to 229. And a third study is looking at a biomarker. This is the PROTECHT study, which looks at tissue factor levels and is only prophylaxing patients with high tissue factor levels and then observing whether we can reduce VTE events in that population. So these are, I would submit, 3 very different and very innovative approaches to prophylaxis. I think as a community, we are moving away from sort of a one-size-fits-all approach to very targeted, very individualized prophylaxis strategies that can include risk assessment, and you've heard some very wonderful examples of how that can be done even in real time using electronic medical records, or it can rely on biomarkers. And it remains to be seen which of these is the most effective way. I think we'll have more information on this in the next couple of years. Currently, guidelines, however, recommend, at least for 2 settings, that prophylaxis is clearly recommended. One is hospitalized cancer patients. There's no nuance about this recommendation. If you have cancer, you're in the hospital, you should be prophylaxed. ASCO says that, NCCN says that, the Italian guidelines say that. For surgery, again, no nuance. If you're in the hospital, you should be prophylaxed. If you're outside of the hospital and you've had major abdominal or pelvic surgery, you should be prophylaxed for up to 4 weeks. This is based on the extended prophylaxis data. For ambulatory cancer patients, currently outpatient prophylaxis is not recommended. The exception is some high-risk patients. The chair of the NCCN guidelines is here. It's sort of rather vaguely worded. I think there's an emphasis on myeloma patients, but the guidelines are currently open to other high-risk cancer patients as well. ASCO and the European guidelines currently are not recommending outpatient prophylaxis, again, with the exception of myeloma patients. And for catheters, we've seen sort of a change. There's been a drop in event rates with newer catheters, and so prophylaxis is currently not recommended. Having sort of described to you how important it is to prophylax cancer patients and to sort of conduct appropriate risk assessment, the sad fact is that prophylaxis continues, even in the settings where it's been proven and has been recommended by the guidelines, continues to be underutilized. In fact, it's so underutilized that it's the most positive variable for whether you would not get prophylaxis in this Canadian study was if you had cancer. So you take the highest risk for getting blood clots, which is cancer, and that's also your highest risk for not getting prophylaxis. It's sort of the complete opposite of what you would want to see, and this has been borne out by many other studies as well. Part of this is education. NATF has done a great job about raising awareness in the hospital community and frankly in the patient community about the risk of blood clots. our cancer population is very unaware of the risk of VTE. This is data from my own institution. One of our fellows did this survey of cancer patients that were coming in to get chemotherapy. More than 1/2 of cancer patients were not aware that they were at risk for blood clots. This contrasts with 100% of them being aware about the risk of nausea, vomiting, febrile neutropenia, and hair loss. So there's a lot of work to be done, both in educating providers and in educating patients. And frankly, again, this is our failure as a community of oncologists and as health systems in not warning patients about what is surely a lethal complication for the disease. Now, if you treat or if you sort of educate patients, that's one thing. This is actually a study of educating providers. Dr. Goldhaber likes to point out that this is an intervention on providers. This was a randomized study of providers, not of patients. They took a bunch of providers at this hospital, half of whom got a nudge. There was an electronic alert that showed up and they were admitting patients, and the other half did not. I point out that this is almost a cancer study. 80% of patients in this study were cancer patients. And there was not only was there an improvement in compliance with prophylaxis, but more importantly, 40% fewer events in patients with whose providers were nudged. Again, there was nothing done to patients other than reminding their providers that shouldn't you be prophylaxing these patients. That tells you the scope of what's possible. 40% of these patients would have developed a blood clot and had to have been on long-term blood thinners with possible complications, with rates of recurrence thrombosis, were it not for the fact that their providers were reminded that they should have been prophylaxed. So when we sort of feel the frustration of having to go to committees and not getting real gratitude from patients because we don't really even see the patients that are benefiting from this, I want you to sort of think about this graph, because these are actual patients that would have developed blood clots if their providers were not reminded about the importance of prophylaxis. And then that's really what healthcare should be about. We conducted a similar setup. You've sort of seen a lot of important ways to improve prophylaxis. We did a similar study at the University of Rochester, which is where I work. We did a couple years of patient provider education and patient education. So there were sort of posters in patient rooms reminding them to ask their doctor to make sure that they're on prophylaxis. Didn't really do a lot to improve compliance. Then we put in these mandatory electronic alerts. So if you admitted a patient, the screen popped up, you couldn't bypass the screen and you had to point out if there was a contraindication, and people were reading the excuses. If there was no real contraindication, somebody would get a call that day. So the graph on the left shows improvement in prophylaxis. So you can see big improvements in adequate prophylaxis. That's the clear bar on the left-hand side versus the post-prompt, close to 80% rates of adequate prophylaxis, and steep drop in no prophylaxis. So almost 50% of patients at our institution were getting no prophylaxis at all, and that dropped to less than 10% just within 6 months of introducing this electronic order entry alert. And this, again, led to improvement for real patients. So these are our data from a couple, 1 year before the intervention, 1 year after the intervention, comparing to a peer group of hospitals that are sort of the same size and have similar setups to ours. This is from the University Health System Consortium. We had rates very similar to the larger peer group pre the intervention. Post the intervention, our rates dropped, whereas the peer group rates went up. And that's sort of the national trend, as you're seeing rates go up. Before the intervention, we were in the middle of the pack. Our rates were about the median for the whole group. But 1 year after the intervention, we were one but last in terms of the lowest VTE rates. So again, these are real patients that did not get blood clots because a group of providers was smart enough to put in an electronic order entry alert. So to summarize, cancer patients are clearly at increased risk for VTE, but this risk is highly variable. Thromboprophylaxis has been shown to be safe and effective in a variety of high-risk settings: hospitalized patients, surgical patients, extended post-operative period, some selected cancer outpatients, myeloma patients, perhaps pancreatic patients. And there are current ongoing studies evaluating the benefits of prophylaxis in the cancer outpatient population. But compliance with prophylaxis continues to be low in the oncology setting. This is a failure of the oncology community and of health systems. There is a lack of education. And health system-based approaches towards both risk stratification and prophylaxis are essential to move this forward. And I can't emphasize enough, all providers for cancer, nurses, pharmacists, physicians assistants, nurse practitioners need to be aware of the risk and consequences of VTE, and the discussion with cancer patients needs to happen at each visit. Thank you for your attention.